Good afternoon, my name is Lieutenant Davis, this is Lieutenant Paris, and today we are going to be doing our EBR on physical agents. So we're going to start out with just our PICO question. What we were looking at is in patients with acute musculoskeletal pain, what is the effect of transcutaneous electrical nerve stimulation compared to no 10s on pain scores. So the P in this, the population, is those with acute musculoskeletal pain. The I, intervention, is 10s. The C, comparative group, is no 10s. And the outcome measure we're looking at is pain. So our search strategy was pretty basic. We looked over some search engines such as Google Scholar, PubMed. The APTA Hooked on Evidence was super helpful. A lot of really good articles on there. In terms of search terms, pretty much everything from the PICO question, we were looking at acute pain, musculoskeletal pain, 10s, no 10s, transcutaneous electrical nerve stimulation for not short. And yeah, pain and pain scores. Great, so the underlying theory for conventional 10s, which is high frequency 10, the underlying theory is based on the gait control theory. So what we want here is we just want a sensory effect. We don't want any muscular contractions. So we're looking for pulse durations between 50 and 80 microseconds. Now, the gait control theory is it's pretty much at the second level of the 5-level model of pain inhibition. So here at the second level, what you can see is you've got these C fibers, which are pretty slow fibers. Both of these cell bodies are found in the dorsal root ganglia. These C fibers transmit thermo information as well as pain information, and they're really slow. While the alpha A and the alpha beta fibers, they are much faster, and they transmit kind of the good stuff for this. What they're transmitting is mechanoreception, proprioception. So in this gait theory, what we're trying to do is we're trying to have these super fast fibers have a positive effect on the inhibitory interneuron, and that inhibitory interneuron will then inhibit the sensory or the perception of pain. And an interesting thing about the conventional 10s is they can actually be worn for 24 hours out of a day, which we'll see compared to the low-rate 10s in this next slide. So the underlying theory for the low-rate 10s is actually looking to target the motor neurons for just small contractions, nothing big. We're not into Russian, we're not doing these crazy contractions, but we are actually trying to stimulate small contractions. So the pulse duration on this is going to be between 200 and 300 microseconds on average. And this is actually working at the third level of pain inhibition, which is where you actually see the stimulated production of endorphins and enkephalines, aka endogenous opioids. And the pretty cool thing about these is that they actually bind to the opiate receptors in the brain, and this leads to pain inhibition kind of in the way that morphine does. So it takes the spot of these harmful neurotransmitters. So that's pretty interesting. And this one you actually only do for about 30 minutes at a time, which we'll see in some of the studies. So our patient population, we're going to detail each patient population for every article, but in general, what we're looking at is, first off, we're looking at acute. And so acute is based on two things, based on the duration of time that you've had an injury for and the tissue status. So duration of time, we're looking at about 0 to 6 days post-injury. And then condition of the tissue is actually in that inflammatory stage. So you're thinking of the 5 stages of inflammation. You're thinking pain, redness, swelling, heat, and loss of function. Musculoskeletal is pretty self-explanatory. It's muscular or it's skeletal. Great, so we're going to start with our articles. All these articles were randomly assigned, so that gives them a little bit of credibility. So this first article, what it was looking at was actually chest fractures, or rib fractures rather. So it had to be a blunt thoracic trauma, and this trauma could lead to either 1 or more fractures. It wasn't specified to whether it had to be 1 or 2 or 3 or 4 fractures, but it did exclude fractures of the first and second rib. So there were 2 groups. The first group received no 10s, they just received basic NSAIDs, while the second group received the conventional 10s. So we're looking at about pulse duration of 50 microseconds. So group 2, that group that did have the 10s treatment, they received 6 treatments total, all of 30 minutes. The first 2 treatments were in the hospital. So right when they got to the hospital, they got a treatment, and then 12 hours after that, they got another treatment. And then they had 4 treatments at home. So on what we're going to call day 1, day 2, they had 2 treatments at home, and then day 3, they had 2 more treatments at home. So the results of this study found that at day 0, there was no difference. So that baseline pain before treatment, no different. Obviously, a rib fracture is a pretty painful thing. So at day 1, so when they were still, so at the end of their hospital stay, so they'd had 2 treatments, there was less pain in the TENS group. So that's a pretty good indicator of the effectiveness of TENS. And then on day 3, at the end of the home treatment, so that's after 6 30-minute treatments, the pain in the TENS group was significantly less. So you can see it's down by about 2 points at day 3, and that is going to be on a verbal 0 to 10 scale. And they didn't clarify if it was the NPRS or just a more generalized, hey, tell me how bad this hurts. That wasn't specified in the article. Okay, so this next one was looking at pain during emergency after somebody had suffered a hip fracture, the transport pain. So for everybody, it had to be their first hip fracture, and they had to be experiencing what was considered severe pain, and that was at 60 or greater millimeters on the visual analog scale. So the methods for this, the pads were placed in what's called the regio inguinalis, and I saw a picture, and so it was actually 2 above the inguinal line and 2 below the inguinal line. With this setup, they were actually doing the low rate TENS, so a 30-minute session of the low rate TENS, which was at 200 microseconds for the pulse duration. Now that was in group 1, and then in group 2, they just put on the pads and didn't put in any treatment. So the treatments actually began on site, so they actually got the informed consent after they had performed the treatment, which I thought was kind of interesting. And again, the pain was recorded on that same visual analog scale, 1 to 100. It was recorded before the treatment and then upon hospital arrival after the treatment. And that wasn't standardized, which I thought was kind of interesting. Obviously, they only did the treatment for 30 minutes, but there were differences in the time spent transporting from the home to the hospital or wherever the location of the injury was. Now, so there was definitely a drop in pain between the TENS group and the non-TENS group. Another thing that I thought was kind of interesting is there was a very significant drop in anxiety as well, and I think that kind of, obviously, pain is something that's experienced subjectively, and so I think kind of just the thought that, hey, something's happening here, and maybe it's just like a little tingle that I feel. Maybe that's more of like a psychological pain relief as opposed to an actual, physical pain relief.
Alright, so the next article that we looked at was TENS for post-op pain relief in total knee arthroplasty, and this one looked at patients that were gonna be undergoing a total knee arthroplasty. The mean age was 73, and they excluded people who had previous total knee arthroplasty on the same, or just general surgery on the same knee. So what they did is they separated the patients into 3 groups. The first one was patient-controlled analgesia as needed, and the patient-controlled analgesia was a solution that included 1 milligram of morphine per milliliter, and it was on a 5-minute lockout. The second group was TENS plus patient-controlled analgesia as needed, and the third group was sham TENS plus the PCA, which is patient-controlled analgesia. For the TENS, they had these 4 pads, and the patients were able to adjust as needed, but they weren't able to turn the device off. And they rated their pain on a visual analog scale for a 24-hour period, and they rated it every hour. And so what they found was they were originally looking at the pain scale, but they found some problems with their patients falling asleep too much, and also the patients that had just woken up tended to rate at extremes. So instead, they had to focus on looking at the morphine intake. So they compared the morphine intake between the 3 groups, and they found that there was no statistical significant difference between any 3. So from that they found that there was no benefit of TENS as a relief for post-op after total knee arthroplasty. Okay, so the next one that we looked at was TENS for reducing acute low back pain during emergency transport. And then this one looked at people who had just had a first episode of acute low back pain. and rated their pain as greater than 60 out of 100 on a VAS scale, and the mean age of this one was 47. They separated the patients into two groups. One group had TENS, and the second group had sham TENS. They had two paramedics. One of them recorded the initial pain and anxiety rating scales, and the second paramedic performed the TENS and did the final pain and anxiety rating scale after they got to the hospital. And they also did the pain and anxiety on a VAS scale. And what they found for this one was that the pain scores upon arriving at the hospital differed significantly between the two groups, finding that the TENS group had both lower pain and anxiety for the VAS scales. And so, in conclusion, here they found that the TENS was effective as fast-acting therapy for patients with low back and acute pain transported to the hospital. Okay, and then the last article that we looked at was TENS for pre-hospital emergency intervention care for treating acute pelvic pain in young women. This one looked only at female patients, and the demographics were there were no significant differences in the demographics of these groups. The two groups were, one had active TENS and the second one had sham TENS. And kind of similar to the other studies, they had one paramedic record the baseline pain and anxiety scales, and then the second paramedic administered the TENS and did the final pain and anxiety recordings. And pain and anxiety were on a VAS scale of 0 to 100, and the results were that arriving at the hospital, the pain and anxiety scores were consistently lower for the TENS group compared to the control group. So now we're looking at safety, effectiveness, and cost. So is it safe? As long as you abide by the precautions and contraindications, we found that yes, the TENS is a pretty safe modality to use. Is it cost efficient? Yes, it's pretty cheap. And then is it effective? In terms of acute injuries, the literature that we found was kind of mixed. So there's no definite answers there, but it may be good for a perceived effect of anxiety reduction. And then the overall recommendations and clinical application, it's cost effective and it's safe. It can supplement a treatment, but should never be used as your only treatment. And then pain is subjective, so if it makes the patient feel better, why not use it?
Thank you.